So welcome. Thank you for your attendance today and your attention. So I'd like to talk about this topic which has become very near and dear to my heart, palliative care and hospice. By disclosure, I'm on the board of directors of the Pulmonary Fibrosis Foundation. So whenever we do a talk from our center, we take our patients with us. So this is we do an annual boat cruise, and this was just last month. Our patients come on this boat cruise, and it's a mandatory event for all of our center staff, faculty and staff. And it's a great time for everyone because we learn from the patients, and they have the opportunity in a closed space to learn and ask any questions. So I always joke with them and say, for the next 2 hours, you can ask any question you want because your doctor or whoever you're going to talk to, they can't go anywhere unless they jump ship. And we get their permission, and they know we take them with us. And it reminds us this is why we do the work that we do. So I have 3 objectives with this talk. Talking about optimizing quality of life, because that's really what it's all about. Defining palliative care, because there's a lot of confusion with it. And then when and how to initiate palliative care. So we really know that patients with IPF have impaired quality of life. Considerations. So this paper was just released in the past month, and it's from the Netherlands group. And it's entitled Optimizing Health-Related Quality of Life in Patients with IPF. And what they're reporting is that the diagnosis of IPF has a negative effect on health-related quality of life in IPF for patients and caregivers. It's the poor prognosis, the uncertainty of the disease course, and the symptom burden. They also report that the effect of the IPF medications is uncertain. And then they promote that research focusing on symptom management and improving health-related quality of life is limited, and so that we should incorporate this as we move forward. So just as a quick review, common symptoms that IPF patients experience. So they experience cough, shortness of breath, fatigue, anxiety, depression, fear of the unknown. And just to reiterate what Wendy said, it's really important to get inside their heads and to ask those questions. And you'll be surprised, but you may already do this, but recently in clinic, I asked a patient, I'm like, tell me about, your cough, your symptoms and that. And then I said, so tell me, what's going on in your mind? And his immediate response was, he said, I'm so scared because I don't know what is going to happen. So it's really important to allow them the opportunity to talk about these things. So another study was just released in 2015, and this was done in England, and it was a multi-center mixed method study of IPF patients and their caregivers, and they were at 4 different stages of the disease. And they did the qualitative these qualitative interviews, and the findings showed that patients do understand their prognosis, but they do not understand how the disease will progress and how it will be managed, and that patients and caregivers both have different needs. So this paper, I'm really excited. This paper was just released in the past month, and this is an international group that has worked to provide this statement, and it's Palliative Care in Interstitial Lung Disease, Living Well. And there's supposed to be 50 copies delivered here from Lancet. I haven't received them yet, but if you see me over the next 2 days and you're interested in the paper, I'm happy to get you a copy of this. But really the focus of this schema is that really it's about optimizing our patients' quality of life, and these are the things that you should consider. Symptom-centered approaches, best supportive care, caregiver-centered management, disease-stabilizing care, patient-centered management, and end-of-life care. And it really is just that focus to get us all reminded of what's the best quality of life for our patients. So defining palliative care. So I learned last month, I thought I've been doing this for a while, and I just learned that October 14th is the World Palliative Care Day. And so on this date, in word of the day, the word palliate was the word. So the definition is to reduce the violence of a disease, also to ease symptoms without curing the underlying disease. So the history, and this is like fascinating, this is for the history people in the room, but it dates back to the 15th century, and the word was originally pallium. So that forms the word palliate. And so literally it was this figurative cloak of protection. So specifically the verb palliate meant, as it still can mean, to lessen the intensity of a disease. So the World Health Organization, this is their definition. And I know you can all read, but just humor me. Palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And the focus is on symptom management and addressing advanced care planning. So how does that differ from hospice? Hospice is provided when an individual is thought to have less than 6 months to live if the illness would run its normal course. And the focus of hospice is on comfort and pain relief. The patient forgoes aggressive treatment. And then you can be reevaluated regularly at these 6-month intervals. So in this schema here, if you take a look, palliative care and hospice, which is the focus of today's talk, where does palliative care figure in the patient's illness? So any patient who is diagnosed with a serious illness, IPF is a serious illness, so they should be offered palliative care. And that can be offered alongside life-prolonging therapy. And really, simply, palliative care is symptom management, as Wendy mentioned, and it's also starting to address advanced care planning. Whoops, okay. So there was this study that really kind of was the game changer. The Temmel study was reported in 2013, where they offered palliative care to a group of patients who had non-small cell lung cancer. And what the purpose of the study was, they compared two groups. They compared the patients who got their standard oncology care, and then they compared them to these patients who received early palliative care instead. And 151 patients were randomized, 107 completed, and the patients that were assigned to the early palliative care, they had a better quality of life, they had fewer depressive symptoms, they had less aggressive care, and they lived longer than the patients who had the standard therapy. So that really, as I said, was kind of the game changer where we started to see more movement in our area. So this next study, palliative care in chronic disease, Bernot reported. So if you take a look here across the top, it's COPD, heart failure, dementia, and cancer. So referral to palliative care for patients with COPD was 20%. Heart failure was 34%. Dementia was 37%. Cancer was 60%. So clearly, we need to be doing better. And this is just one of several studies published by Sabrina Bajwa from England. And she did a study where she looked at palliative care in IPF, and she looked at 45 patients. And what she reported was that in their last year of life, 42 of the 45 patients experienced breathlessness and benefited from standard pharmacologic treatments such as morphine and opioids. Now, the majority of her population died in the hospital, and the minority had palliative care involvement. And what they also learned was that the documentation of patients' preferred place of care and death is poor. So one of these notes to self for you, if you're ever asked to provide your signature for a death certificate, most patients with IPF don't have listed idiopathic pulmonary fibrosis as their cause of death. Typically it's respiratory failure. So it really is hard to track long-term what happens and how many people are dying from the disease. So then we took a look at our center, because this is what was kind of a driving force for me. I was working with our physicians, and I noticed that there was a disconnect between what the physicians or the provider was saying and what the patient was hearing. And I had a few patients say, but no one ever said he was going, or not patients, caregivers say, but no one ever said he was going to die. And I thought, you know, we have to improve this communication. So what we did is we took a look at our center. Our center's been in existence since 2001, and we did this study where we looked to see where did all of our patients who died from IPF, where was their location of death, and did they have a formal referral for palliative care. So we had a total of 860 patients, but we had 465 decedents. Of these 465, the transplant recipients, we took them out of the study because once you have a transplant, you don't really have IPF anymore, so it just muddies the water. So what we did is we took a look, and we could find known location of death for 277 patients. Now, we couldn't find it for 127 patients, and for those of you who are in big centers, probably you might have the same thing. You see a patient once, and they may not come back. So you don't really have that established relationship. So here was our experience, and this was the key finding. So in this first table on the left, diagnosis to death. So what we found were in this patient population, median survival from diagnosis to death was 3 years. Now this next table was first center visit to death. So it was 1 year. So what we found in this particular study was that there was a 2-year delay from when patients were diagnosed until they arrived to our center. So you think about that. If you read the literature, and patients go to the literature and Google right away, and they come in and they say, oh my God, is it really true? I have 3 to 5 years. And as we have talked earlier today, we know that the disease course is variable. But what we found is, this was in our patient population. This was also reported in 2001 by Talmadge King, and again in 2011 by David Lederer's group. So then I had a student that was working with me, and she needed the project, and this finding emerged. So in those patients that we saw, there were 860 patients. We had 106 patients who went to the ICU. So we took a look at, and when you take a look here, so this is their first center visit to ICU admission in months. So we had 34% of our ICU admissions occurred within 4 months of their first center visit. Okay, most centers you see your patients like every 3 to 4 months. So what happened in this particular sample is that we had these patients have 1 visit with their provider, and there's a lot that goes on at that visit. So these patients ended up, they died after 1 visit, and they didn't, there was not that established relationship. There was a median of 9.5 months between the first center visit and ICU admission. Now, of those 106 patients, 74% died during that first ICU admission when they did go, but everyone in that group that went to the ICU, they died within a year. So we did some focus groups with patients, caregivers, and caregivers of decedents. And we wanted to get more feedback from the patients about palliative care. We did a support group for them, and there was some cautiousness in the room just about this. But what we found was that there were 4 themes that emerged. That patients and caregivers have a definite need for education, and they said what they receive in the community is quite different from what they received at our center. Impact of symptoms. Symptoms were a big impact for patients and caregivers. And one of the biggest symptom was cough, and there were patients, spouses who specifically reported that they were working during the day, but at nighttime the patient's cough was so dramatic that it interfered with their sleep, but they couldn't go to a different bedroom because they just couldn't do it. So, just reinforcing this impact of symptoms. The other finding was they really didn't like the word palliative care and asked, could you please call it something else? And then they did report that they had comfort in our center because they felt that there was a home for them and that there were resources. So, the last part of the talk is when and how to initiate palliative care, supporting data and decision aids. So you saw this slide before today, and this is the biggest challenge is how do you bring this up when you know that the disease course is so variable? But you just kind of have to go back to the idea that it is a serious illness. At the time of diagnosis, it is really important to talk about just the impact of the disease. And there are some new decision aids that have just become available in the literature. So this was just released just in the past month in the Annals by Steve Nathan's group. And they have this algorithm where they, if you take a look here, so they use a 6-minute walk as a decision aid. So if the patient needs to stop, if they have an oxygen requirement, Borg scale, pulse rate recovery, SpO2, and distance. And so if you take a look, and you can just follow through, but if a patient has a Borg scale greater than 6, they suggest a palliative care consult. If we go back, patient needs to stop, they need to go to pulmonary rehab, they really should have a transplant referral, and at the same time, palliative care consult. So this is what they reported in their group. There's another really nice decision aid that has, this is part of that first paper, Health-Related Quality of Life in ILD, and this is out of the group in the Netherlands, and this is the ABCDE, and so it's assess, backing, comfort care, disease-modifying treatment, and end of life. So they provide a nice structure for how to discuss and to implement care across the continuum for patients. So just when you think you're, okay, I'm starting to get this, then you find out, you dig a little deeper, there's a little confusion with palliative care. So there's primary palliative care, there's secondary palliative care. So palliative care can be delivered by an interdisciplinary team. That's referred to as the specialty palliative care. So if you think in your institution, if you have a palliative care program, those are the specialty people. Then there are palliative care practitioners who are trained in conducting discussions regarding end-of-life planning, and so it might be good to involve them. And then because palliative care focuses on assisting patients and family caregivers to better manage the symptoms associated with the disease progression, primary and/or specialty palliative care should ideally occur early following diagnosis. So who's primary care? That's you as the provider. Specialty palliative care are the actual specific programs. Now the challenge. Do you speak with your patient or caregiver about the serious nature of the disease? This is when you walk out of the room, this is the takeaway. So do you speak with your patient about this disease? Palliative care is confusing. Reframing it as quality of life is suggested. An early discussion is recommended with ultimate goal to address and reduce symptom burden and advance quality of or advanced care planning. Really just reframing it, I want to help you achieve the best quality of life possible. So how do you find it? So this is a really nice resource that our palliative care nurse practitioner shared with us. So this website, caringinfo.org or getpalliativecare.org, find a palliative care team. This is a way to find it in your community. This is available across the United States. And this is a busy slide, but this is the example of when if you go to that palliative care, this is what you'll find. And they actually have you, you put your state in, then you put your region. And I see some people frantically writing That's good. We want you to do that. So I'll take a minute while you just get that. Yes. Please take a picture with your phone. Please write it down. This is really the meat of how you help your patients. Okay? All right. This is one of our patients. When she got the diagnosis of IPF, her response was, ooh, this is not good. I have a lot of things left on my list that I want to do. She came out of the visit, she went to her husband, and she said, I want to go to Australia. And so here she is. She brought her picture back, and here she is dancing with the natives with her oxygen. And she said, please share this with patients so that they can know that yes, you can get on. And then special thanks to the people that I work with. We are one big team. And so with that, I don't know if we have time for questions, or if you have any questions, I'm happy to. Okay.